A very good evening, everyone. Thank you for having me here, Ashisa. It's always a pleasure to be here with you. Um, so, uh, so my topic today is robotics in TKR, my experience with the Mako. So I will be speaking a bit of our journey as well. So I guess what we want to say is like, see, we have a lot of surgeons, we have the artists who give us good patient outcomes, we have the good surgeons, decent outcomes, then we have the carpenters and the butchers as well. So though they're probably in the minority, but they're still there. So we want to try to start uniformizing the results. So I think technology will help in that. If you can, oh sorry, you're running fast. क्या हो गया? Yeah, sorry. Okay, so we want to make sure that we start uniformizing the results. So for that, I think technology will definitely help. So make sure that everyone gets the right knee, everyone gets a good knee. Right, so our joint replacement robot is the Mako, so I'll be speaking specifically about this. And of course, there are the other players on the block now. All of them are good, as was mentioned in the earlier, and even Dr. Minal was saying. They all have their own advantages and disadvantages, but I'm speaking specifically about the Mako. Just a quick look at the evolution. So in the 1950s, there were static plans, and navigation came in the 90s. Navigated freehand tools like the Navio robots came in the early 2000s, and robotic arm-assisted surgeries like the Mako also came in around the same time. I'm not going to bore you through this, but the major things are in 2010, the Mako total hip came up. The Navio came around 2012. Then you have in 2016 is the first TKR done with the Mako, and now the Velis has also come up with their own robot, their Pews. So a quick look at the classification. You either have image-based or image-less, and the Mako is an image-based robot. Does it do everything? Not this particular robot. It's a semi-automated one, so it only assists us. So as you've seen in the surgeries today, and the hip in the morning and then the uni as well, you have a haptic boundary and it prevents you from going outside that, but you're still wielding the knife. The classification of robots as per this criteria is either boundary control like the Navio or the Cori, semi-autonomous like the Mako, and the fully autonomous like the QVIS. I think there was a QVIS surgery which was demonstrated yesterday. So this is, I'm sure you've all seen these, just a quick run through of these. It's a handheld Cori, and this is a fully automated QVIS robot where the surgeon does not have to hold the instrument. So this is the Mako. You have the boundary control, the haptic boundaries, where it auto locks into the correct plane and it doesn't allow you to go outside the boundaries. Right, so the Mako can do all the three, and I think if you really want to get the benefit out of the robotics, you have to start embracing new personalized alignments. So earlier we were all putting mechanical alignment because we didn't have the wherewithal to go for functional. Now we can just adjust the implants in different angles, in different degrees of degrees, and we can get a properly balanced joint. So if you look at this great paper by Sapi Manier, mechanical alignment and functional alignment, if you just compare these two, the target is 0 degrees, it's a mechanical cut, and in functional you can go up to 5 degrees either way. And the coronal cuts are the same. Target is 0 degrees in mechanical and 0 plus or minus 3 degrees in functional. And if you want to do functional, it has to be robot assisted. You can't do a functional alignment without the assistance of technology like robotics. So what's the need? So if you see the advantages of robotic TKR, there are 3 core features, that is enhanced planning, dynamic joint balancing, and robotic arm assisted bone prep. We like to call it as ABC: accurate sizing, balancing, and 100% precise cuts. So the 3D planning is you have to do a CT scan here, and all these are put together to form a 3D model. So this is called as segmentation. A 3D model of each particular patient is come on the screen, and you can actually plan out your implants accordingly. So you can have a lot of information here, like better understanding of the osteophytes and bone defects before we even go into the case. Then of course you can plan for stem extensions, augments, and bone grafts before we even start the surgery. You can shape match the femur in the trochlear groove, the medial lateral fit, the posterior condylar offset. Now we can actually match this. Earlier we were not able to do that. Sagittal planning also can be done, like slope of the tibia, flexion of the component, and we can actually calculate the combined flexion together. Then as I said earlier, you can move your components in 6 degrees of freedom, that is femur and tibia, coronal, sagittal, and axial. Then, of course, there's the dynamic joint balancing. So intraoperatively, you crank up the joint, you see what are your gaps, and then you have to start trying to balance those gaps. After you've balanced it, depending on whether you want a mechanical alignment or functional alignment or kinematic, whatever you want, the final execution is done with the help of the haptic boundaries. It prevents you from going out and hitting your soft tissues and prevents you from taking out the normal bone. So you have extra amount of safety here. So the quick look at the workflow: pre-op planning, the OT setup, arrays are placed, registration is done, intraoperative adjustments are done for ligament balancing, then you resect the bones, and of course the trial reduction and implantation. Okay, I'm not going to go into too much of depth on this. This is what a balancing looks like. Let's see, these 4 boxes have to be balanced to 18. So you can first put your tibia in 2 degrees of varus. You can see the lateral gap is closing down now. And then I can bring my femur, so anchor my femur, and give another degree varus here. So this gap closes up, the extension lateral gap closes. Then put it in flexion, anchor it medially, posteriorize my femur, and again give some external rotation now. You see what happens here. The boxes close up. And you see now we are nicely balanced in terms of the gaps. So that's what we can do. And of course at the end, we use the haptic boundary to prevent hitting out any soft tissues. So what about procedure time? That's what we were discussing just now. We're not only time neutral, but actually faster. 45 to 60 minutes is if you're doing it really relaxed. Nowadays at our institute, they're doing it often 35 minutes. What it means for the patient: reduced surgical time and blood loss, unparalleled accuracy, smaller incisions and reduced tissue trauma if you're embracing functional alignment, less pain due to reduced soft tissue dissection, and faster recovery. If yes to robotics, then why do we like Mako? It's the only CT-based system that recreates a 3D image of the pain. Now it's no longer true. QVIS has also come in. Only robotic arm is with an intelligent tool holder where you don't have to use cutting jigs. It's only one which has all 3 applications: THR, partial knee and total knee, and it has the haptic technology as well. And it means less pain in 90-day post-op period, 92% patient. These are all in fact 5-year-old studies. In fact, we have more studies now on these. Less bone and soft tissue damage, less need for analgesics, less time to discharge, etc. So just quickly look at our journey, because he asked about our experience. We first saw a Mako in action in Australia in Jan 2019. That was an eye opener actually. When we saw the hip, that's actually when we were hooked. And then we went and finished our training in New Jersey and in Florida. And this is Dr. Suhas and I had gotten certified at the MAVA Cadaver Lab in New Jersey. We got certified in the same. Feb 1st, 2020, we launched our Sunshine Orthorobotics department. And PV Sindhu had come to inaugurate it. So she did a first cut with the robo on a sawbone. And we had Dr. Thomas Kuhn, a designer surgeon of Mako, to come down, and we actually made him hit a coconut as well in our style. And our first Mako TKR was on Feb 1st. We actually got the certificate from Stryker of being the fastest 200 joint replacements, robotic joint replacements. In 21st Jan, we launched the hip, and present numbers, we've crossed more than 5,000 surgeries with the robo, including total hips and partial knees. And we are now certified trainers, so we don't have to go to New Jersey to get certified. We are training surgeons from around India and the world as well. We also certify them. So what have we learnt? End of the day, have we taken anything from the robot? Yes, we have. We've learned that people embrace the technology much quicker than we thought. We thought it was going to be a hard sell because they're shelling out more money, but patients are coming and asking us now, we want robotics. And a few older patients were actually arguing with us why we didn't give them that option before. Learning curve is not that steep as we expected. The uni that you saw today, it didn't take me too long to pick it up. We have embraced personalized alignment now. Earlier we were completely mechanical alignment, but now we see the advantages of functional alignment with the robo, which leads to less pain, faster rehab, and we can do complex cases as well. What about our outcomes? That's what matters. This chap is on the day of surgery. So with functional alignment, we're not doing any more soft tissue release. I just need a minute. So they're able to move the knees without having much of effort and with much less pain. Cross deformities also. You can see patients like this, able to get completely straight. Valgus knees also were able to make sure that they're walking well. Okay, and even patients like this with implants in situ, we can do the proper planning and make sure that we avoid the screws. We don't have to take out any of the plates and plan the surgery that way. You have patients like this with gross malunited tibias with 18 degrees uncorrectable varus. We're able to correct them completely. And this gentleman is a father of an orthopedic surgeon. with such severe deformity, he managed to get away with a very well-balanced knee. Why are we getting better results? We're maintaining the internal homeostasis of the knee, titration of bone cuts in functional alignment, less ligament release, haptic control with less inadvertent soft tissue injury, and less time with the knee subluxated. We don't need to subluxate the knee until we're preparing the tibia. So none of the cuts require the knee to be subluxated. We are now doing our own study now, where we are doing a double-blinded randomized control trial. One side is a bilateral knees, one side is being done manually, and one side is being done with a robotic in the same patient. So we are coming up with the paper very soon. And this is a publication from our center, Enhanced Mid-Dissection Workflow for very, very severe varus deformity knees and how to do it. So end of the day, all robots don't have to be the Terminator, the villains. We can be friends with them. And of course, I thank Dr. Ashish Singh for having me here. And it's always a pleasure to be here. Thank you so much.
Thank you, Doctor. May I invite Dr. Subhas